Hi, my name is Cecilia, and I will be doing a case study on insomnia in an elderly client. So we have Rita. She's an 80-year-old Caucasian woman, and her chief complaint is difficulty falling asleep, and she wants to take Ambien. To give you a little bit of background on Rita, she came to see me about 3 months ago with reports of insomnia, and I referred her for cognitive behavioral therapy and educated her on sleep hygiene techniques, such as avoiding caffeine after noon, sleeping in a cool, darkened room, avoiding daytime naps, things like that. And in addition, I asked her to track her sleep using a sleep diary. So today she reports that she has been going to therapy about once a week. She has been using the sleep hygiene techniques that I recommended and has been keeping a diary, but she's still having a hard time falling asleep. She says she lays in bed for up to 2 hours before drifting off to sleep. She's kind of tired of all of the behavioral tasks that I've given her and states, I've tried all that crap and it is not working. I need a sleeping pill. I've had Ambien before. Can you give me some of those? She said she has been taking Advil PM for the time being, but that hasn't really been helping. She said she's really frustrated with her insomnia and she feels drowsy all day, and it's really preventing her from participating in activities that she likes to do at her local community center. So her past medical history includes atrial fibrillation, hypertension, and hyperlipidemia. She's currently taking metoprolol and Coumadin and doesn't report any side effects from those. Socially, she is widowed. She's been widowed for 10 years. She currently lives with her daughter. She drinks about 1 to 2 alcoholic beverages a month. She doesn't smoke, she doesn't use drugs, and she exercises about 3 times a week. Her physical exam today is within normal limits, no fever, blood pressure was 126/78, heart rate was 80, O2 sat was 97, she's 5'4" with a weight of 138, no recent sicknesses, her lung sounds were clear, and she really doesn't have any other complaints. So as far as her workup for insomnia, the diagnosis of insomnia is really made primarily on symptoms. There's no lab work that we can do to diagnose somebody. If somebody does have a more complex medical history, they may need further testing. For example, if she had COPD, we might want to consider exploring hypoxemia, or if she had sleep apnea, we might do a sleep study. But really, sleep studies are kind of held off unless somebody has a comorbidity or if all other treatment options have failed. The American Association of Sleep Medicine does recommend doing questionnaires to rule out a psychiatric disorder. They also recommend doing the Epworth Sleepiness Scale to determine the severity of the sleepiness. And then they also recommend doing a sleep diary to see what other factors might be associated with insomnia. So, insomnia is defined as a complaint of trouble initiating or maintaining sleep, which is associated with daytime consequences and is not attributable to environmental circumstances or inadequate opportunity to sleep. And the American Association of Sleep Medicine outlines two goals of treatment: one, to improve sleep quality, and two, to improve related daytime impairment. And I'll be referring to the American Association of Sleep Medicine's guidelines throughout this presentation. So, what treatment options are available? So, first, it's really important to determine if the patient is suffering from chronic insomnia or if it's related to an underlying condition. If it's related to a psychological disorder, for example, that should be the focus of treatment. For Rita specifically, beta blockers can cause insomnia, but she's been on metoprolol for several years without any side effects, and it's managing her blood pressure well. So I'm not convinced that that's the cause, first of all, and I don't really want to mess around with that treatment if it's been managing her blood pressure well for so many years, and she's really not having any other side effects from it. To treat insomnia, the AASM recommends that the first-line treatment should be lifestyle factors and cognitive behavioral therapy. These lifestyle factors, as I mentioned earlier, include avoiding caffeine in the afternoon or before bed, not exercising right before bed, not napping during the day, etc. And these interventions are actually shown by research to be more effective than pharmacological treatment in the long term. But for some people, just those interventions are not effective on their own. So for pharmacological therapy, sedative hypnotic drugs are the most common medications prescribed for insomnia, and they work especially well with therapy. So these drugs include non-benzodiazepine receptor agonists, and these are not habit forming, which sets them apart from other medication options. We have benzodiazepine receptor agonists, and these come in short, intermediate, or long-acting formulations. The long-acting benzos are rarely used because given their long half-life, their effects tend to flow into the daytime, which is something that we don't want, especially for an older adult. And then we have a selective melatonin receptor agonist, and Ramelteon is the only option for that type of drug. We also have sedating antidepressants, which tend to have a lot of side effects. We have antihistamines, and that's what's found in most of the over-the-counter medications thought to have benefits for sleeping, like Advil PM or NyQuil. Unfortunately, the long-term safety and efficacy haven't been found for those drugs, so they're not recommended for chronic insomnia. Another option is melatonin, which is a natural supplement. Unfortunately, research is not really clear for this medication, and it hasn't been shown to be super beneficial. And then there are other natural supplements that some people take, but again, there's not much compelling evidence for their efficacy. So the ASM recommends this kind of stepwise approach for treatment. They recommend starting with, and this is of course after therapy and lifestyle factors have been initiated, but for starting pharmacological therapy, this is what they recommend. So they recommend starting with a short or intermediate acting benzo or Ramelteon. If that doesn't work, they recommend trying a different short or intermediate acting benzo, again, or Ramelteon. And then from there, they move up to the medications that have more side effects, like using a sedating antidepressant. If that doesn't work, using a sedating antidepressant with a short or intermediate acting benzo or Ramelteon. And then if none of those work, then you can get into other sedating agents like anti-epileptic drugs or atypical antidepressants. So we want to consider what might be best for Rita, and really our main limiting factor for her treatment is her age. So you may have heard of the Beers list, which is a list of medications that aren't appropriate for use in a geriatric population. Several of these medications are used for insomnia are on this list, including Ambien, which Rita wants to take, and Advil PM, which she's already taking. These drugs aren't recommended to be taken because they can increase the risk of falls or they're risky for delirium. Other options used for insomnia, benzodiazepines or antidepressants, are also on this list. So really, out of all of the options that were given, we're only left with Ramelteon and melatonin. And as previously stated, melatonin doesn't really have compelling evidence for its efficacy, and it's not approved by the FDA. And then aside from all of that, I really want to consider whether Rita even needs a medication. She's already taken the steps to improve her sleep hygiene and is participating in therapy, which is first-line treatment, but it doesn't seem to be helping. So it may be that she needs to give these interventions a little bit more time to work. On the other hand, I'm concerned that if I don't provide her with treatment, she'll continue to take Advil PM or other over-the-counter remedies that aren't really safe, but she wants to use the medication, so I'm worried that she'll use them anyway. So I would rather prescribe her something that I know will be safe for her. In addition, insomnia has been shown to be related to poor balance, slower reaction times, impairments in cognitive function, depression, anxiety, impaired quality of life. So for me, I would rather treat this insomnia for her safety. And of course, it doesn't necessarily have to be a long-term treatment. Maybe she just needs some medication to kind of let the therapy kick in, and see if we can wean her off of it in the future. So I'm going to choose Ramelteon, which is a melatonin receptor selective agonist. So melatonin is a hormone that regulates sleep-wake cycles. When the body receives cues that it's time for bed, such as when it's getting dark outside, the body naturally releases melatonin. There are 3 melatonin receptors. M1 receptors are involved with sleepiness, M2 receptors are involved in regulating the circadian rhythm, and M3 receptors aren't related to sleeping. So giving melatonin directly is thought to help people who work night shift, for example, and don't release melatonin naturally, but it does have a really short half-life and it's not selective, so its results are not super effective. Ramelteon is different because it has a longer half-life, 1 to almost 3 hours, and it's selective to M1 and M2 receptors. So its benefits are shown primarily for trouble with sleep onset, which Rita has. Its side effects are fairly mild. Some examples are headache, dizziness, nausea, and fatigue. It is metabolized in the liver primarily by CYP1AC, so it does interact with CYP1AC inhibitors. Some examples are antidepressants or antibiotics. It does interact with other sleep medications, any other medication that causes CNS depression, and it shouldn't be used with high-fat foods. The benefits for Ramelteon is that it's not habit-forming and it's safe in the elderly, which is great for Rita. So as far as Rita's teaching plan, I first want to explain to her why I don't want her to use Ambien or Advil PM. I'll explain the Beers List criteria to her and just emphasize why these medications are not safe for her. I do want her to continue attending therapy and to work on her sleep hygiene. These interventions work really great alongside pharmacological treatment, and hopefully she doesn't need pharmacological treatment for the long term. And hopefully, after these interventions kick in, we might be able to wean her off of the medication. But for Ramelteon, I'm going to teach her to take 8 milligrams, which is 1 pill, 30 minutes prior to bedtime. This medication should only be used when needed, and it should only be taken if she has a full 7 to 8 hours that can be dedicated to sleep. I'll educate her that if she doesn't notice an improvement in a week, then we can reevaluate her treatment, but she should not take any other sleeping medications in addition to this. And I also want to encourage Rita not to take this medication with a high-fat meal before bed. Otherwise, it may not work well for her.